So today, chapter 42, eye and vision problems, all right? So a little bit of anatomy and physiology. You guys went over the eye in A&P, okay? So eye changes associated with aging. So these people will have reduced visual function, structural changes, and functional changes. So everybody knows, as you know, our population that we're dealing with is the older adult. You know, we're the more geriatrics part of med-surg. So as somebody, you know, as their age increases, their eyesight starts to kind of go. Same thing with hearing, you know. Some of them are selective, you know, but usually like selective hearing, but usually with eyesight, it's really because they can't see. It's not because they're choosing not to see, you know. Arcus sinalis, this is an opaque bluish white ring within the outer edge of the cornea. It's caused by fat deposits. So these people have difficulty adapting to dark environments. Health promotion and maintenance. So you're going to teach eye protection methods, sunglasses, things like that. Nutrition. So you want to make sure they get that beta carotene. So think of when you were younger and your mom's like, oh, eat carrots because they're good for your eyes. That's where the carotene is found. Eye examination. So usually it's an annual eye examination. If they go to the ophthalmologist and they see something, they may want them back more frequent. Head and eye protection, those are for those people that work outside. Think of those microbiologists, maybe mixing chemicals or whatever they're doing. They should have the proper eye protection. Washing hands. You touch something, you want to wash your hands. A lot of times you touch something and then we do this, you know. This is very common. You see this with kids. They do this and they do this, you know. They got pink eye, they got this, they got that. We're down the whole chain of command here. Eye drop technique. When you guys are doing eye drops in clinical, you want to make sure, A, your hands are clean. I would highly suggest you put on a glove. You want to make sure you have a glove on, you put the conjunctiva down, pull it down, and then you put the eye drop in. Usually I recommend to put the eye drop in the outer corner, and then I tell them to close their eyes and make a circle so that it goes all around the eye. And managing other health conditions. Sometimes with people that have eye disorders, cataracts or anything like that, it can be caused from something else, maybe diabetes, hypertension, along those lines. So if they can, take their blood pressure medication and get their blood pressure under control, they wouldn't have these eye problems. All right, so history, age, gender, occupation, what do they do as leisure activities? If they have any systematic health problems, comorbidities, anything like that, drugs, do they smoke, vape? Nutrition history, are they vitamin deficient? Are they deficient in that lutein or that beta carotene? Family history and genetic risk. So a lot of times when patients come in, if they have, obviously you have to understand, a patient is not going to come in to the emergency room and say, my vision has been going, because then we refer them to an ophthalmologist. Something has to happen, whether they're completely blind in that eye or, they're not going to say for the past 3 months, this is what's been going on. Usually you see them in the clinic, they'll come in because they want help. They don't know where to go. So we would refer them to ophthalmology, try to give them as much information as we can. But truthfully, the ophthalmologist has to make the diagnosis of whatever's going on with them. And they would say, like, my grandmother and my mom and my aunt have always had glasses. I kind of know I'm going to have glasses too. Current health problems. Their diet. You want to make sure that they have fruit, red, orange, and they have a good abundance of dark green leafy vegetables. Red and orange, yeah. So like anything red and orange, think of it like that. And green leafy vegetables. Physical assessment. So they'll do that head tilting and squinting, and we'll talk more about that. Then they do symmetry. So when you're looking at the patient, you want to make sure that what you see on one end, you see on the other end, okay? That they both look equal. Hold on one second, I'm sorry. Same thing with their brows and their lashes, symmetrical, okay? If, let's say, you're looking at somebody and they look like they have a facial droop or something, what are you thinking? Stroke, right? You're thinking stroke at that point. So that's why we want to note positive symmetry, that they're symmetrical on both sides. Eyelids, they could have that ptosis, which is that drooping of the eyelid. Sclerocorneal pupillary assessment, that requires your pen light. What else is there? Vision testing. They'll do that blink reflex. That's where we look to make sure the pupils respond to light. A sudden or persistent loss of visual sensory perception within 48 hours, they should notify the doctor. Okay, so if somebody wakes up and they can't see anything and it's blurry, they should notify their doctor right away. Visual testing, we're going to measure near and distance. So our Snellen chart measures distance, and our Rosenbaum chart measures nearsightedness. So you want to assess ocular function with the light. So you're going to put the light in and make sure that obviously the pupils are reacting to that light. Rosenbaum. B-A-U-M. That's how I say it. That's nearsighted. So your Snellen is the one that you go to the doctor. Everybody knows the Snellen. You go to the doctor, like hold your eye, look at the letters, say it. Or you go to the ophthalmologist and you're sitting there and they start putting the things in front of you. That's the Snellen chart. Lab assessment, they'll do cultures, conjunctival swabs and scrapings. So now if the eye is drooping, let's say gunk, are you allowed to take a swab? Yes, because it's not invasive. You're just catching what's coming out right then and there. They'll do imaging assessment. So your CT is very useful. Your MRI is used to diagnose tumors. Your radioisotope scanning locates the tumors. There's no special follow-up with this. And then your ultrasound is a painless test. The eyes are usually closed, or what they do is they instill drops, have the patient close the eye, and then do the ultrasound. The one thing you want to tell the patient out of an ultrasound is to please do not rub your eyes. Because a lot of times, A, the hands are not washed and they're doing this. And B, it messes up the test with the chemicals that they put in. So you want to just not rub your eyes, just kind of let it be. Other diagnostic assessments. So you have your slit lamp examination. This looks at the anterior eye structures. Your corneal staining, which is looks at the fluorescent on the conjunctival sac. Then you have tonometry, which is your intraocular air. Ophthalmoscopy, looks at the external and internal features of the eye. So usually when you go to the doctor, the eye doctor, they will look at it. They will do more detailed of your eye, okay? Especially if your patient has comorbidities like diabetes and hypertension. Fluorescent angiography is a detailed image of the eye circulation. Electroretinography looks at the retina's response to light stimulation. Agonoscopy measures increased intraocular pressure. So let's say they do a tonometry, right? And it's positive that this patient, the intraocular pressure is high. Now they would do a agonoscopy to see how high it is. Okay, we'll measure that increased intraocular pressure. Ocular coherence tomography, I hate these words, is a three-dimensional view of the back of the eye. Now, if you have a patient that comes in and doesn't understand English, okay, or is confused, are you going to start looking in their eye? No. It's common sense, all right? Common sense is not really the thing these days. But, so you want to avoid using an ophthalmoscope with a confused patient or one that doesn't understand the language spoken, okay? Especially if you don't have an interpreter. They don't understand. Now, here you go with the thing. They're going to be like, what the hell is this? They don't understand.
For any of them, right?
For any of them, yeah. So this is that test that we were just talking about for intraocular estimation. So that's where they go, they look, and then you get the puff of the air. Ophthalmoscopy, again, where they're looking. Red reflex, okay? They're looking for that red reflex, okay? If a kid does not have a red reflex, remember that's a medical emergency, okay? They have to go to the hospital. All right, cataracts. So cataracts is the lens opacity that distorts the image. Very common these days with everybody has cataracts. Both eyes may have cataracts, but the progression is different in each eye. So one eye may go first, where they start to like see that blurred vision, and the other eye is fine. And then maybe a couple months later, while they're getting treatment on that one eye, the other eye starts to kind of get cataracts with it. So with that, it can be present at birth or develop at any time, often age-related or caused by trauma or exposure. And it can occur with other diseases and and eye disorders. Who does it affect? So it's age-related. Cataract is most common. So most people by the age of 75 will have some kind of cataracts. How do we avoid it? So avoid heavy sun or UV light exposure. Wear sunglasses, wear eye and head protection. And if they smoke, guys, anybody in the world, what are you going to say to them? Stop smoking. History. Have they had any recent or past eye trauma? Exposure to chemicals, exposure to toxins, use of certain drugs that can affect their eyes. We know that if they're on lupus, right? If they have lupus and they're on the hydrochloroquine, eye exams every 6 months because it can cause damage. Right. So exactly. So you want to make sure that if they're on certain drugs. Intraocular or systemic diseases, family history, smoking history. Early signs and symptoms of cataracts, they will have blurred vision, decreased color perception, photophobia. No problem. Blurred vision, decreased color perception, photophobia. And then late signs and symptoms of it, like when it becomes late, they will have that diplopia, that double vision. They will have reduced visual acuity, progressing to blindness. And then they will have that clouded pupil progressing to a milky white appearance. All right, so we went over signs and symptoms, hypothesis. All right, so what are we going to do? All right, so surgery, only way to treat it. All right, in order to get, better, they have to have some kind of surgery. Pre-op, you're going to get consent. You're going to assess how reduced their visual fields are. You want to teach them that before and after surgery, they will have several different drops at several times a day. So it won't be all the drops in one shot, okay, for the next 2 to 4 weeks. Also, we want to ask them and communicate to the doctor if the patient takes anything to lower their blood pressure. All right. So remember, you have to tell them. We want to also teach them how to put the eye drops in, because you don't want it to be at the end after they have the surgery and they're like, oh, I can't do it. Nobody wants to send somebody to a nursing home to instill eye drops, because it's not a safe discharge. Operative procedures. This is where they will replace that intraocular lens. So that clouded lens, they'll take out and they replace it. Post-op. Immediately after surgery, antibiotic and steroid ointments are instilled in the eye. The patient is discharged within 1 hour of procedure. You're going to instruct them to wear dark glasses in lit areas. So if you see somebody wearing their sunglasses at night, you know why. All right. You're going to teach them to schedule for their eye drop. So you're going to say this eye drop, we write it down for them, 9 a.m., 10 a.m. You're going to stress follow-up of visits, okay? So a lot of times when patients have this surgery, the next week or so, the vision starts to get better. I'm like, oh my God, I'm healed. Yes, this is great. Never have to go back to the eye doctor again. No, you have to go for your follow-up visits, all right? Mild itching is normal, you're going to tell them. They may have a bloodshot appearance, like to the eye. Their eyelid may be slightly swollen from obviously holding it. Avoid aspirin because of blood clotting. You're going to instruct the patient to call the MD if pain and nausea and vomiting are noted. You want to instruct them and teach them, educate them how to properly wash their hands. All right. You want to, if that person is going to do it and they have difficulty, that's why we start in pre-op, because we want to make sure that we're also teaching that person. If they can't, if that person getting the surgery can't do it, that we're teaching that person, the new person, how to do it. We're going to teach them the eye drop regimen. Return demo of eye drop installation. You want to make sure that they're not just yesing you to death and they're leaving. So you want to make sure, no matter who they are, that they return demonstrate it and that you document it. Some patients are prescribed to wear eye patches. All right. So you want to make sure that if they are prescribed to wear an eye patch, if the doctor's prescribing them to wear that eye patch, let's say 14 hours a day, that you tell them, all right, from this time, from 8 a.m. to whatever time, that's when you're going to wear it. What else is it? Avoid activities that increase intraocular pressure. So usually I tell them, like, lay low until you see the doctor again. Don't go out. Don't start running. Don't do pickleball, things like that. Like, don't go golfing with the small ball and wait, take it easy. Stay home. Relax. Enjoy your house. Avoid rubbing their eyes for 3 to 7 days. A biggie for the ladies, not really the men, nothing against you guys. But you're going to tell them, no vacuuming. Yeah, no vacuuming. Avoid it because of the jerking motion. They don't, because it increases the pressure. And you're going to tell them avoid driving until their vision is clear. After a week, they feel great. They're like, oh my God, this is great, but their final and best vision is not till 4 to 6 weeks. So I usually tell them, wait for the doctor to clear you, and then you can drive. What else is there? When the cataract is removed, the lens is gone, making prevention for falls important. Okay, so you got to be very careful with this. Remember, the client's safety is always the priority. All right, anything with sensory, think of sensory, guys. Anything sensory, you're thinking safety. All right, next one, glaucoma. This is increased ocular pressure, all right? And there are different types. So you have primary, which is your most common type, and that's from aging, heredity, things like that. And then you have secondary. Remember, secondary from something that it's caused by. So iritis, I can't say this, whatever. Trauma, ocular tumors, etc. Anything that goes on in the eye. And then you have associated. Think of it like this. It is associated with something. All right. So diabetes, hypertension, things like that. Secondary is something happened that's making it. So like trauma, ocular tumors, think of things like that that are not comorbidities. It's characterized by increased intraocular pressure that involves gradual painless vision loss that can lead to blindness if untreated. So it's very important that we treat it. Who gets it? African Americans over 40 years old and any individual over 60 years old, especially Mexican Americans, those with a family history of glaucoma, and adults with high blood pressure, corneal thinness, optic nerve abnormalities. It's very common these days. You'll meet somebody in their history, glaucoma. Same thing with cataracts. Most common cause of blindness in North America, and there are 3 million adults with it. Scary. It's a lot of people. All right. So with that, they should have their eye examinations regularly. So if they have no comorbidities, they should have an eye exam every 2 to 4 years before the age of 40. All right. So sometimes, like, let's say young kids, they go to see the doctor, the ophthalmologist, they'll clear them 2 years, come back in 2 years. We don't need to see you for, until there's a problem or whatever.
2 to 4, you said?
2 to 4, yes. History. You're going to ask them about their vision loss. It's usually a sudden onset that brings them in for it. Signs and symptoms. So early signs and symptoms of a glaucoma are that increased intraocular pressure. They have decreased accommodation or ability to focus. Late sign. They'll have a loss of peripheral vision. They will probably start to see halos around the lights. That scares me because I see that sometimes. They'll have a decreased visual acuity, not corrected with glasses. So they go to the doctor gives glasses, and it can't be corrected. It's not corrected. They come back for follow-up, like, listen, it's not working. These glasses are crap. They're not working. A big one for a late sign is a headache. Or they say like an eye ache they have, like my eyes are like strained, like from trying so hard to focus. All right, diagnostic assessment. So they will do a tonometry, which measures the intraocular pressure, a perimetry, and then they'll go to a gonoscopy. So remember what I said with the tonometry is where they will look to see the intraocular pressure. Gonoscopy is where they will measure how high it is. Okay. Optic nerve imaging, they will get that all done with the ophthalmologist. Supporting visual acuity via health tracking. So drug therapy is on page 945 in your book. They will usually get a prostaglandin agonist, which reduces intraocular pressure by dilating blood vessels. So a big one that we usually give all the time is called lantoprose. What do you want to get out of this? You want to teach these patients, A, wash your hands, and B, proper eye drop care. You also want to teach these people that early detection, lifelong treatment, and closely monitoring. Okay, it's a lifelong thing. Usually glaucoma is found on routine visits to the eye doctor. Surgical management, they'll do a laser trabeculoplasty, which burns that trabecular meshwork and it scars it, causing that eye to become tighter. So it takes that trabecular, like a muscle in the eye, they will go in there and kind of like zap it, and that scar tissue will cause it to become tighter so that the vision is more center on, like you could see better. Trabectomy, removal, creates a new channel for fluid outflow. So they don't have that pressure, has a new way to get out the pressure. Both of these surgeries are ambulatory surgery. So the patient comes in the morning, they're home for lunch or whatever it is. What are we going to do with these patients and teach them? You're going to teach them proper eye drop care, managed care. So they should see the eye doctor every 1 to 3 months, depending on like what the doctor recommends. Good hand washing. Do not skip doses of those eye drops, because remember, those help with like the pressure of the eye. For the people who get surgery, okay, you're going to teach them about cortial detachment. It can occur afterwards. So what can happen is like heavy coughing or sneezing or straining of stools can detach the cortial. So they have to be very careful. So a patient like this, we're going to send home on a stool softener, okay? And you're going to tell them when they sneeze to just be very careful. But you want to make sure that they're not overexerting themselves, okay? Because that can lead to the cortial detachment. Patient, you have to put the eye drops in. Patient has to be sitting up, like because of the pressure. You can't lay them down with that. They have to be sitting up at that point. It was the wildest thing, but it's a real thing for eye donation. You have to be very careful. Like there's a special way to take care of the eye and preserve the eye until they actually remove the eye and implant it in another human being. I think eye donation is in here. Yeah, it is. All right, so they're going to get an eye donation. So you're going to instruct the patient to lay on the opposite side. They're going to have a patch. So you're going to teach them patch use, okay? You're going to say, doctor wants the patch on for 15 hours. You're going to put it on from 7 a.m. to whatever a.m. or whatever, whatever they have it for. They probably will need the eye shield to wear to bed. So it's a patch with a shield, like to make sure that nothing is touching that area. Teach them how to put in eye drops. They should avoid jogging, running, and dancing.
Bouncing around.
Yeah, like bouncing around. Don't vacuum, I guess. Complications of this surgery are oozing, bleeding, and wound leakage. With the eye, you'll be able to see it, obviously. They should report bleeding and decreased vision. Has anybody ever heard this term? I'll explain it more if you haven't. Floats. So floats are when they're looking, they see like those little things coming, in their visual field. So when you're looking at the eye, you could see the blood pooling in the eye. So this is how they do it. So eye donation. So they will go through the eye bank. See, I told you, there's Association of America that has published the eligibility. So the person has to be eligible for it to get that eye. So care of the potential eye donors at death. You're going to elevate the head of the bed 30 degrees, apply these antibiotic eye drops that appear in the magic sky, and close the eyelids and apply an ice pack, okay, over the eyes. So you're going to close them. Sometimes, not to be dramatic, but sometimes when a patient dies, their eyes are open. So you want to help them to close the eyelids. And then if the eyelids will not stay closed, you can put a piece of tape over them because you want to put an ice pack over it. All right. Remember, these eyes are going to help somebody else see. So that's the rationale behind it. All right, retinal disorders, macular degeneration. This is a mild blurring and visual distortion. And the treatment really focuses on slowing the process of these people. Retinal holes, tears, and detachments, often caused by the posterior vitreous detachment. It could be a sudden, painless onset. They'll have bright flashes of light or floating dark spots. What are we going to do for them? They'll have that laser photocoagulation or cryopexy. So that's all laser. Then they can have surgery. All right. So pre-op for the surgery, patients are very anxious and fearful. So we have to provide them with support. You want to restrict their head movement before the surgery to reduce retinal detachment. So if it's detached, you want to reduce it from detaching more. And if it's not detached, you want to reduce it from detaching altogether, like because people are moving around. So you want them to kind of relax. An eye patch is placed over the eye to reduce retinal movement so that they can't focus on anything. Post-op, they're going to be put in an eye shield. We're going to check their vital signs. You want to make sure they're stable, that everything's within normal limits. You want to teach these patients to report sudden increased pain. This is the key to this, okay? You remember how the other one was like, you got to be careful with the driving. This one is no reading and writing, your favorite. Anything that can require them to focus because the retina can detach, okay? So until they're cleared by their ophthalmologist, they are not to be reading and writing.
This is for
this is for the surgical. So retinal holes, tears, and detachments.
So do not read or write until cleared.
Right. Retinitis pigmentosa. This is the retinal nerve cells degenerate and pigmented cells will grow. These people have night blindness. Maybe that's what I have. Loss of peripheral, then total vision, and then they have a lacy, heavy pigmentation. I don't know, like in the hospital, I don't know if you would see them, but in a nursing home, I feel like you can see them. When you look at their eyes, it has like that lace. It looks like a piece of lace right over their eye, a lacy pigmentation of it. What are you going to do? You're going to avoid drugs that affect the retinal cells. And these people should wear glasses with UV protection, okay? So when you're educating the family, you're not going to tell them, go on Amazon and buy a pair of glasses. You're going to tell them, see a doctor and get the real deal thing, okay? A lot of them are like, I don't know why this is getting worse. Well, I bought these glasses on Amazon for $400. Well, they don't have no UV protection. Trauma. So the care varies depending on what the trauma was. Was it penetrated? What happened to these people? Is it a foreign body? Is it something like maybe they were doing something and the glass exploded or something, a light bulb, this happens sometimes, light bulb, and then they get it in their eye, not realizing it. What are you going to tell the patient? Obviously, never to remove anything. Don't put your hands in your eye. Let's say they got a pencil. The kids do the dumbest things, Don't remove it. We have to send them for help, okay? You want them to remain still until help arrives, okay? Because the more that they work themselves up and walking around and this, that, and the third, that pressure builds up, keeps building. So you want them to relax. Let's say they get a piece of glass in their eye and it's not sticking out of the eyeball, but it went in their eye. Or a chemical in the hospital. They should use those eye wash stations, okay, and flush the eye completely. you have to just keep washing the eye, washing the eye, washing the eye. All right. And it's not the fun. It's really not fun, but literally it's a burning sensation. So with penetrating injuries, remember, never pull it out. Okay. Relax the person, sit them down, let them relax until help comes. Okay. Or somebody, a specialist comes to evaluate them. Um, Lacerations, we want to wash the eye out to make sure that, obviously everything is coming out. And obviously they need to come to the hospital. Anatomy and physiology of the ear, you guys know this, you know where to find obviously the external features of the ear, the inner features of the ear. So we start with the middle ear, and then we talk about the inner ear. Okay. Usually if somebody has like otitis media, something like that, it usually starts in that middle ear. When you go in and look, it's not that pearly, you can't see like the pearl, you see like pus. Okay. It looks dark and gray. We'll go through that. The tympanic membrane. Okay. So remember, tympanic membrane, when you're looking inside, it should be pearly pink. All right. You go and look in, let's say a kid, and it's gray, angry looking. They usually have some kind of otitis media. It looks like it's mad at you when you go in there. Ear and hearing changes associated with aging. So some changes are harmless, others may be threat. Okay. As somebody gets older, their hearing starts to go. Not all the time, but I feel like they've become selective hearing. They hear what they want to hear, and then the family's like putting on these hearing aids on them. Sensory perception, so hearing loss. So it can be conductive, which is an obstruction or a sound wave. And then you have sensorineural, which is the inner ear or cranial number 8 are damaged. Yes, conductive is an obstructive sound wave. So think of the C in conductive, think of can see. Okay, think of it like that. When you look in the ear, you can see something's going on. You could see if they have wax. You could see if there's maybe some idiot kid put something in their ears. You can see it. Okay, so that would be conductive. Sensorineural, you cannot see. So that's the inner ear, because you can't see the inner ear, or cranial nerve 8. You can't see cranial nerve 8, guys. You know, you're going to test it, but you can't see it like that. Or it can be a combination where there's something blocking it, and now it's affecting, now it's been a while, now it's affecting that cranial nerve 8, or it's in the inner ear as well. Conductive hearing loss can be caused by inflammation and obstruction of the external or middle ear, changes in the eardrum, or otosclerosis. Okay, so they have something blocking in there. Sensorineural hearing loss, this is damage to the inner ear or auditory nerve, which is cranial 8. So this can be prolonged exposure to loud noises, ototoxic drugs, or presbycuspis, which is degenerative of the cochlear nerve. So with this, it's estimated to be 15% of the adult population between 20 and 69 years old develop this. So you're going to ask them about the history, the hearing changes. So usually the patient will say, like I woke up and I started to see that, I started to notice that like I couldn't hear one day. I don't know, maybe I was swimming in the ocean and the next day I couldn't hear. Maybe it was water. I thought it was water, and then it's just becoming worse and worse, or whatever it is. Their age, how old are they? Exposure to noises. You get people that like work outside in an environment, maybe they're construction work and they're using the jackhammer. Now they have to wear those ear, whatever they are, but they used to not wear them. Hearing loss was at an all-time high with them within their population because everybody was using this and everybody was hearing it. It's all they were hearing all day. History of ear issues. If they have a history as a child of ear infections, okay, things like that, that comes back to haunt them. You're going to ask them when you look in, you're going to see if they have any excessive cerumen. And you're going to ask them when they get up, when they're laying down and they get up, are they dizzy? Okay, and what do we call that? Vertigo. Okay, so signs and symptoms. An otoscopic examination is done by the healthcare provider. So they'll go in, they'll look, all the whole 9 yards. Psychosocial assessment. So communication struggles. These people feel depressed. They feel isolated. It's very hard when you can't hear somebody, and you can't say, how you feel, like you can't, you have to lip read. Not everybody's keen to like reading people's lips. Laboratory assessment, so their white blood cell count. So if they have some kind of like otitis media, like an external ear infection or some kind of infection, their white count will be high. Imaging assessment, they'll do skull x-rays, so otitis media with bone involvement they could see. CT MRI will show soft tissue and presence of tumors. And other diagnostic assessments, the audiometry, which is where the audiologist will perform this for sound and pitch to make sure. It's like that one that you have to listen to it. You put the earphones on and you have to hear the beep. Planning, and what are we going to do for these people? So increasing the hearing, non-surgical, early detection. So disease treatment of otitis media, we're going to give them antibiotics. If they have hearing loss from just not hearing, we're going to give them amplifiers. Those are like those the hearing aids, things like that. In the hospital, we put the headphones on them and you talk in the mic. Everybody saw that? Love that one. Flashing lights they give, it's called another kind of hearing aid thing. They can do implanted devices. So implanted devices improve bilateral sensorineural. Another thing they can do is lip and sign language. And managing anxiety, believe it or not. Because it's a lot of anxiety when you can't understand, when you can't hear. Surgical, they'll do a tymphoplasty, which reconstructs the middle ear to improve conductive hearing loss. So remember, with conductive, you can see. So one sign and symptom of conductive is like that eardrum is misshaped. So that's where they'll do this tymphoplasty. They'll reconstruct that canal. Assure the patient that hearing loss post-op is normal because they're going to pack it. So a lot of times it's not like that cataract surgery. They wake up and like, oh my God, I can see. It's almost like they wake up and like, wait, I really can't hear, even worse. But it will get better because the packing will get removed. You're going to tell them that post-op forceful coughing should be avoided. You want them, the operative ear facing up for 12 hours. And you want to direct your conversation to the good ear. You're obviously not going to talk to the person with packing in the ear, like, then it can hear you. Home care management, provide written instructions. So as much as you're going to tell them, you want to provide written because their hearing is not all there at that time. In 6 to 8 weeks, they have to come back for follow-up. And you're going to teach these patients how to instill eye drops, okay? Eye drops, room temperature, never in the refrigerator. Why? Because you put them in and it makes them very dizzy. The cold makes them very, very dizzy. So not too hot, not too cold, has to be room temperature. Otitis media, this is ear pain. Hearing may be reduced. They'll have tinnitus, which is the ringing of the ears, headache, malaise, nausea, dizziness. What are you going to give them? Analgesics, antihistamines. Sometimes it's caused from allergies, decongestants, and they may need a possible myringotomy, which is a fancy word for ear tubes, okay? Now, if a child has had, they say it's like 4 to 5 ear infections within a year, they should see an ear, nose, and throat doctor, okay? For possible tubes in the ears, okay? Because they get that back up and it will help them. So it's a surgical opening of the eardrum. You can get it as adults, but you don't really see it as adults like that. Huh? What? A myringotomy? Yes. Yes, myringotomy, yeah. Otitis media. That's the only, it's one of the ways to take care of it. External otitis. So otitis externa. This is painful, red, swollen external ear, often caused by irritating or infectious agents. They may have temporary hearing loss with it. Usually with these people, when you go to pull on their tragus or their pinna, they will have like this ear pain whatever. We also associate this as called swimmer's ear. All right. Somebody who doesn't wear earplugs, they go swimming, they're a swimmer, they get otitis externa. So you want to remove materials from the ear canal, heat to ear 3 times a day, so meaning like a heating pad over the ear, and topical antibiotics and eardrops. Again, eardrops have to be room temperature. What else? Meniere's disease. So this is episodic vertigo, tinnitus, and hearing loss, okay? It occurs in people between the ages of 20 and 60 years old. Hearing loss is reversible at first, yet if it's repeated and constantly repeated, they will have permanent loss. So you're going to teach the patient to move slowly. They may need vestibular rehabilitation therapy, drug therapy, and a labyrinthectomy. Where is my thing? When a patient with Meniere's disease gets up, those are the patients that you're going to sit and you're going to dangle them, all right? And you're going to wait because you have all the time in the world. And then you're going to get them up, okay? Slow and steady wins the race.